Our panel discussion follows the very timely topics of the morning on attachment readiness for systems change. Our discussion will be moderated by Marco Campana, the Knowledge Mobilization and Social Action Coordinator from Access Alliance. And our panel consists of Dr. Jen Rayner, the Director of Research and Policy at the Alliance for Healthier Communities, Cliff Ledwos, the Acting Executive Director of Access Alliance, Dr. Alamgir, the Director of Organizational Knowledge and Learning of Access Alliance, and Dr. Rosie Yoon, Scientist and Professor with the University of Toronto. Marco, over to you.
Thank you very much, Courtney, and I'm going to let everyone do a quick introduction and a reflection on what you've heard so far from our previous panelists. So we'll start at the end, Cliff, and work your way over. I know, Ryan.
Okay. So I'm Cliff Ledwos. I'm the Acting Executive Director at Access Alliance, formerly Associate Executive Director. I worked with a number of OHTs who are present here. I'm on the board of the Alliance for Healthier Communities. And I garden and collect ceramics on the side.
And your reflections so far.
Oh, and my reflections. It's not all about me. I keep forgetting that. Well, a number of them. The walk-in clinic piece, I'll grab some time probably during the panel to talk about. One of the things that I did want to reflect about was this, what I think a theme that I'm hearing a lot of in the speakers that have been talking to us this morning is the active and the passive. So we have a system right now that is passive. It is a person having to identify, oh, I need a doctor, oh, I want to get connected, oh, I want to take care of my health. If for some reason a person, for whatever the reason is, I cannot do that, I don't trust the system, I can't, I won't, I don't belong, I don't feel connected, then we sort of do nothing, we just sort of leave them. So what we're really, I think, doing here is we're talking about a system that is going to be an active, engaged system. So we're going to go out into the community and we're going to identify the people who, for whatever reasons, are not engaged, are not attached, are not accessing, and we need to do that work with them. We need to identify them. We need to have those linkage moments, the link people, the link programs, so that we can identify those people, we can address the concerns that they have, so that they are then fully able to engage in the system. So it's a revamp, a redo. Maybe it's wiping the slate clean. But we have to have an active system, an active health system that seeks out people and puts that opportunity into place for them to be able to engage fully and properly in the system. And I have more, but over to you, Jen.
So Jen Rayner, I'm the Director of Research and Policy at the Alliance, and I wear a few other hats. I'm an Inspire Primary Healthcare co-lead, I'm an ICS scientist, and I have a few academic appointments. But my heart and soul is with the model of health and well-being, which we talk about a lot at the Alliance, and I've sort of grown up in community health centers, so that's sort of where I come from. I think my overarching reflection is I'm so pleased to think about us doing things differently. So we can't just think about people that are coming into our organizations anymore. We need to look at the whole population, and that includes, like Sarah talked about, the neighborhood health home, but it also includes building partnerships with people we might not have partnered with before. And I think that's the other key piece, and that's where the link worker comes in. That's where leadership comes in, that are so good at building partnerships with other organizations that you might not normally partner with. Like Cliff just said, walk-in clinics, bring them into the fold. They don't need to be seen as the bad cousin. They are a critical service. So how do we do that in a way that brings them into the fold? So everyone's attached, but they're getting the services they need when they need them. So lots to talk about over this panel. Thanks.
Thank you. My name's Rosie Yoon. I'm a nurse practitioner, but also assistant professor. The type of research I do is health services research, especially integrated care. And I always say I drank the OHT Kool-Aid really hard. I believe in the OHT because I did my postdoctoral work with the Midwest Toronto OHT, and I drank it so hard because I realized that was like 4 or 5 years ago, and I'm still there supporting evaluation research. And the Kool-Aid I drank was an integrated care approach. And the reflection I have today is I love the stool with the 3 legs. And I've been like thinking really hard, which is a big deal because I'm not that smart. So I'm thinking hard on the seat, like where your bum sits. And to me, the seat is our population. And take a regional, where you live, work, and play. And when I look at the population, remember intro to stats, the curve, the bell curve. Yes, the bell curve. Every one of us falls within that curve, and we're all different. And for me, the important aha moment is when you talk about primary care attachment, equity, access. Let's think about the seat. And everyone on that seat falls different across the curve, across your lifespan, from birth to death. So you might be a hipster drinking your, whatever drink, walking around King, Queen, West, and you don't need anything other than whatever, vaccines for your trip somewhere. But later, when you are 77, you will be coming to see me with your 4 chronic conditions, and I am going to be worried about your hip fracture. And this is why attachment matters, because in Canada, the Canada Health Act funds physician services and hospital services. And when you're 77 after that hip fracture or need to be referred, if you don't have a primary care physician or provider, that door is locked to you. So when I'm thinking about the seat hard, and to your point, we need everyone at the table to meet everyone across that standard distribution.
Thank you, Rosie. Standard distribution. Bell curve. My favorite topics. So, my reflection is that I'm not sure from where I have to start, because I was so engaged with Sarah's keynote speech that I want to repeat every word, every sentence. And I focused my thinking process on 2 solutions: team-based care, team and mandate. We need integration of team and also integration of mandate. I loved so much that may be the masterpiece that we can start working on. Yes, Sarah, thank you for your tripod, that analogy. I used it in many places, in my article and many places, with your reference that yes, it is. And I loved how you connected access, equity, and attachment. Because we are speaking about attachment. And as my colleague Hosama said, that at one point of time, attachment and equity, there will be conflict and confrontation between these 2. So this is the time I want to end my reflection. I am with you to do evaluation. We need an inbuilt evaluation. I loved the word you used, rapid assessment program of the government. That is fantastic, but it is rapid. I love the program. That is very much timely needed, and I like your wording. It is aggressive initiative. So let's move forward, evaluating a realist evaluation of the attachment process. Not the numbers only, but quality and sustainability. Thank you very much. Yeah.
Thanks, everybody. So I'm going to invite the panel to build on what they've said, but also what has been said, but also to go down a completely different path, if that makes sense, and to riff off of each other. I kind of want to start with the big question that Sarah presented, not as a question, but what do we need to do right now? We have 3 years of an attachment-focused mandate that is simple to politicians because it's numbers, right, as you said. It's very specific statistics, but we all know that it's much more than that, below the iceberg, as Kasia showed us, for example. The struggle is complexity. The struggle is the people that are left behind, as Cliff said, who are passively not engaged. So the third leg is now a fourth leg is the engagement, right, that we need to do. We can't just be passive with equity, and that's how we connect it. So Sarah mentioned that we'll get the stats are the simple one. The attachment is simple. The access may be next, a little more complex, but the equity, how do we get to the equity? And part of that may be through engagement. It may be through the system sharing with each other that we talked about, the acronym that you're going to speak to, Jen, perhaps, the acronym SOUP of our health sector. And I think one of you mentioned walk-in clinics as like the bad actors, right? The bias we even have within our own systems about how everyone is actually a healthcare actor, but there are perceptions of those kinds of things. So what do we need to do right in the next 3 years to move beyond just the stats and move into access and move into equity and move into engagement and move into areas that we may not have even thought of, but that the people we're going to talk to are going to tell us are important to them, so that we make sure that the seat on that chair or stool is actually something we take into account as well.
Oh, it's on. So I'm looking at the crowd because Anne Wojtek was here in the morning, and she wrote with Jodim Goldhar a piece in Healthcare Quarterly, which was published a couple of weeks ago. It's a framework for sense making, from condition-based to advancing a continuum of integrated care towards population health. Why I say you should all read this? Because this piece tells us that building a true healthcare system is like evolution. It evolves. And primary care attachment is like a first piece. And the reason is our healthcare system is designed by the Canada Healthcare Act that funds physician services and hospital services. So we have an illness care system based on managing chronic conditions. That's what we have. What we're trying to transform in the stool is to support our population, your neighbors, ourselves, and everyday people. And in the population, towards population health kind of based approach, there's a tension between the traditional walls of the house that is designed to fund doctor visits, primary care attachment, and make sure that when you need a hospital, you're there, is not responsive to population health. So what we need is policies, and it's great from the keynote, legislating primary care is a big policy move, right? So you also need to broaden that to legislate population health care, because the things that keep you healthy is actually your job, the walkability, Andrew Larson left, but ecological health of a city, and not just nurses, I would say, and doctors. I would say your sense of civilian kind of sense of health and health literacy. In fact, early childhood health. And so if you start there, you're linking it back to social determinants of health. And so where I see to enable this work, my perception, it's limited, is that action follows where money flows. And look at your social services, look at your Toronto Public Library, look at your daycare services, look at your early immigrant settler services. They are not funded through a healthcare envelope, right? And we have a Ministry of Health, we have a Ministry of Labor, Ministry of Immigration. Not that all of us have to be one mega ministry, but this is where the OHT Kool-Aid is coming strong. The vision of Ontario Health Teams is to convene. And with the walk-in clinic the walk-in clinics are part of an ecosystem, right, that keeps us healthy, and we need to bring folks in. And so if policy and legislation could adopt an ecological framework, I think we're then moving from condition-based planning and pathways, which is necessary. That's why it's one of the legs. But then to your point from the audience earlier, that doesn't then directly compete with equity and access. And so we have to think about the seat. Who are the bottoms, the bums on the seat? and what are their needs. And so that requires, from a research perspective, a segmented population health approach. We need to know who's in this region, how many of them are what age, what do they need, and that allows the relational process that Kasia was talking about of who needs that high touch.
For me, I think the neighborhood health home is a population-based approach, so I really feel quite strongly towards that. And I'm going to get into some nitty-gritty things that I think we can do pretty easily. One is centralized intake, because I think that by design has an equity-based approach. And that way you can have this population approach and ensure people get the care they need. I think the next big thing is to employ a learning health system approach. If we can rapidly learn from each other, like what we're hearing today, we're learning from each other, then apply it, and then don't get stuck on those ideas. Throw it out if it doesn't work and try something new. So I think that learning health system approach and learning from each other is pretty key. I think a great example is group intake, and we've heard about that so many times because the bottleneck, everybody is trying to see more people, but the bottleneck is how on earth are we going to attach all those folks quickly? Group intake works really well. Get other people, get all those unattached folks, get them ready to be attached for primary care, and it works. We've seen several examples. We've got case studies. We've got a learning collaborative that teaches people how to do this. I think the whole person's perspective. Have link workers. Sarah's talked about a lot of this stuff. You can tell we work each day together. But I think the other thing that's really important is measurement drives behavior. And I think if we're only measuring attachment, that's what people are going to be focused on. And that's where equity and access kind of get pushed behind because there's no reason to even focus on it because we're being measured and laser focused on attachment. So I think we need to universally embrace the collection of socio-demographic and race-based data, equity stratify like Rosie talked about, and then just see what's working and what isn't working and make sure we're providing access to everybody and that there's no equity disparities. So those are some really tangible things I think we can be doing, and I think there's so many people doing it well. We need to spread and scale what we're learning. And I guess one more thing is try not to be competitive. I think sometimes with these EOIs and these processes, we pit people against each other, and we need to stop that. I think if we embrace this neighborhood health home, we've sort of moved competition aside. We're saying, okay, for this population, we need to provide care. One organization can't do it on their own. We need to do it together. So how do we do that in the best way?
Sure. So, the walk-in thing is like pushing my angry button when we talk about walk-in clinics and that they're not useful. They are a diamond in the rough in the system because they are all about access. What's failed is not the walk-in clinic itself, because there's professionals who are working in the walk-in clinic who know what they're doing and do provide the care that's needed in that particular moment. What's failed is that we haven't connected the walk-in clinics back to or between ongoing care. So how do we utilize walk-in clinics in those right moments for those right purposes? Like, I have a sinus infection and I need to be seen today, but my doctor can't see me for my ongoing doctor can't see me for another 7 days. Why can't I go to a walk-in clinic, have my sinus infection taken care of, but my doctor should know that I've been to that clinic? And those walk-in clinics need to have a level of care that meets the needs of all of the people who walk in their doors. They've got to have access to interpretation. They've got to be culturally aware. All of those things that we should expect from everybody else in the system. But we have to take this wonderful tool and we have to be able to make it work for us in the system. Okay. Sarah used the word terrifying. I'm gonna 5.2 times in her opening remarks, and when I hear Sarah, who's not a person who's frightened of getting into the mix of things that are going on, we do have to be careful because it is a terrifying moment, and the terrifying moment is that there's a bit of a setup that's happening writ large. And so the government has put out a challenge to us to attach a certain number of people. And if that doesn't happen, they're not going to be responsible for it not happening. We are going to be responsible and at fault for it not happening. And that's what terrifies me. And so we cannot fail in that because, and like many moments where an opportunity is given to a population to make it work, make it right, the failure is that terrifying piece. And so if you're not successful, you're going to get blamed, it's going to get shelved, and nobody's going to pay attention to it again for another generation, and then it'll be offered up as this little, piece of fruit that we all want to be able to nibble at. So we cannot fail. We do have to attach people, but more importantly than that, we have to think beyond 2029. And that is the three legs of the stool. That's that seat where people can put their bums very comfortably onto that stool and feel very comfortable in sitting there and feeling comfortable in being able to utilize those three pillars. Sarah, I think you also used the word nuance. We have to pay attention to the nuances. That is part of the learning health system. That is part of quality improvement that so many of us are involved with. And we learn from success and we learn from failure. And we cannot be afraid of small f failures. We have to learn from them and then try something new. Fails people in practice, I think, was another thing that you talked about. And so we cannot fail people in the practice piece. We have to be able to learn constantly. We have to be able to try something on, and if it doesn't fit, then stitch it up, try it again, and if it doesn't work, then go on to something new. I do think that OHTs are an important mortar for the bricks that we have in our system. They can help to glue all of those different pieces together. This does feel like an important moment with the OHTs for those of us who have been around for a couple of years, but you can't tell from our faces. We've seen this before, but this is new. And this is different, and I do think that the OHTs are playing a really critical piece in bringing people to the table, helping to make it less competitive and more collaborative. And so lots of credit to the OHTs. Rosie talked about drinking from the OHT. I've had a vodka tonic from the OHT. Love it. We'll keep going back to have another sip because I do believe in the OHTs, and my experience in the OHTs has been very, very valuable in bringing people together, getting our brains thinking, and being inventive and creative in all of the work that we have been doing. Yeah.
Okay, so Cliff told the total story that we must not fail. We are here not to fail, but what we can do not to fail, because nobody fails because they plan it. People fails because they don't plan it. Now we are at the right intersection of the attachment readiness program. We can plan so that we don't fail after 2029. What we can do, yes, we have couple of models, neighborhood homes model, we have concierge model, these are tested, we have navigator, intermediary roles, that is less uttered in the system, intermediary roles that Kesha and Rosie, we are working on it and they are working. So attachment, if as a program attachment, if we connect them with OAT, Ontario Health Teams, with navigator roles, with the open door roles, like open door as an example, open door like programs roles, and centralized integrated. Another important thing for attachment that our physicians or service providers, nurse practitioners, they are frustrated about administrative workload. How we can reduce that? Because our system EMR is not portable. If I am registered with Scarborough Health Network, if I tomorrow go to UHN, I have to register again and all those 1 million data again. So it is a burden for the healthcare system. So it is an easy solution, that it is easy, less investment, but huge impact. Transportability, portability of the EMR and data integration. Equity data, requirement data, needs data, sources availability, service and demand. So this data integration learning health system that Sarah told, Jennifer told, so those are the things that I can think. These are the nuances, blind spots that we can, this is the right time we can start working on it side by side with the attachment program.
Thanks, everybody. Jen, I want to ask you, because Sarah alluded to the work that you're doing from a policy perspective with the government. So what do we know about the government to allow us to build this parallel path to access and equity while we achieve the attachment goals so that we don't fail and that we can continue to build?
I think we're trying to work with the government.
But what do we know about what they need?
Yeah, okay. So I think what we know they need, what we hope they would do is we wish they would provide a bit more direction. So we know what works. We know what works really well. So why does everyone have to recreate the wheel? It's forums like this that get people talking and they're like, wow, that's a really great idea. The neighborhood health home feels like there's a few people doing it. Why on earth do we have to keep doing this on our own when we've got good ideas? Let's just share them and make them a bit more directive. I think people would cherish that. I think we need to collect equity-based data. We need to ensure that team-based care is part of the solution, which they're doing, but still it's quite physician-focused. So I think we need to do that. I think we need to, oh my goodness, there's so many things. Yeah, sure, Sarah.
So sorry.
No, this is great.
No, I don't want to come up at all. I just want to say that one thing we know they need is a very detailed plan on how to get from A to B.
Oh, yeah.
We have, and so we're right. You're working on this. A very detailed, all the steps that they need to take to make it happen. And so we're developing that right now and hoping that government will then put it into practice.
Yeah. So I guess what we're doing is we're building a neighborhood health home toolkit. And what we had done before is we'd kind of enveloped this, we had this access and attachment toolkit, and one of the chapters was about neighborhood health homes. And we'd written up case examples, we had the vision, we had recordings of presentations, and it was going well. But I think like Sarah said, we need a ABC, this is what you need to do. We've also got toolkits for teams that are trying to implement the neighborhood health home. We've got toolkits on how to increase access and efficiency using a learning health system approach. So we're trying to provide very tangible steps because it can be done. We just need to do things differently. And I think, the other thing is I think they're learning in baby steps. So just in the last month, they've recognized the sort of power of sharing ideas. So we've created a community of practice that is being co-run by Primary Care Collaborative and Ontario Health for all of the new teams because they recognize, for some reason they're adverse to sharing ideas directives, but they're hoping people will share good ideas, and that's what we're doing. And we're sort of building a community of practice based on these sort of pillars of what we think should happen to kind of attach folks within a neighborhood health home.
So we're not entirely sure what they need, but we know they need step by step. They need their hands held, and they need it to be as simple as the stat for attachment.
Yeah, I think we know what they need. They're just not hearing it properly, and they, for some reason, can't do it.
Right. So there's a knowledge translation piece that needs to happen within some of that makes sense to them at the same level that attachment has made sense to them in terms of the investment, the ROI, things like that.
And I think it's a political thing. I think like the attachment is a political thing. And I think we're dealing with the reality of what this means. And so I think it's when you have political decisions driving behavior, it just gets tricky because it's a number that everyone is laser focused on, and it's so nuanced.
So building on that, Cliff, and the failure fear, and AKM, you can jump in as well. As representatives of a service providing organization, what do we need to do to move from the theory of attachment and attachment readiness, which we've heard is quite complex still, to create actual attachment with equity and access at an individual organizational level?
Yeah, I think pardon me. A part of that is putting some creativity and innovative programs like Open Door into place, where you can, for lack of a better word, experiment, get out into the community and see what actually works and what actually doesn't work, and what may work for one population may not work for another population. And again, that's okay, because not all populations are the same. And every population needs things that are unique and specific to them. And some things will cross populations, and those are the pieces that we have to discover. So when we come up with programs like Open Door, when we come up with the community team, when we come up with those innovative programs and services, we have to take them, we have to put them into practice, we have to learn from them, we have to accept the failures when you see it. You have to accept the successes and build on them when you see it. But you cannot be afraid to experiment and to try new and innovative ideas. You cannot give up because the program or the service may not fit that exact particular moment in time that is a political directive and not actually a need that the community has. So again, I think part of it is I recommend that we are thinking beyond 2029, and I think we have this sense in our society that government knows the answer, and I think actually it's quite the opposite. I think government actually doesn't really know the answer, and to varying degrees, different political parties who are in government know even less of the answer than others may. And so we actually do have to create what the system looks like, and then we have to advocate for it. We have to continue to do the research and collect the data to prove our point. A number of years ago, Natisha Moskwai, who is the executive director at Women's Health and Women's Hands, stood up and said, everything that we need to know is in the data. And I had one of those oh my God moments, and it totally changed the way that I thought about things after that, because in fact everything is in the evidence, everything is in the data, and we just need to continue to do research, continue to collect data to prove and to demonstrate, not to prove, to demonstrate what we already know. Yeah.
Well, I appreciate the political actors, because that's a policy window. That's a real thing, and so that's really important, because my piece to this is we need to evaluate and measure things. And as a health service researcher, we can evaluate outcomes upstream. It's hard, but there are people with big brains and PhDs and whole careers, economists. We need health economics. We need to do cost-benefit analysis. We need to cost-effectiveness modeling so that we can speak the same language. And I think we have a taxpayer-funded system by all of us. We own this. And so if you're talking about the next political election, the policy cycle, the world we're living in is under economic restraint. And so to make that pitch for evidence is evaluation research. And so my Achilles heel is when I hear people have detailed maps of programs, I'm like, that's a logic model. And so when you're providing that detailed how-to the politicians who have a short electoral cycle, they need to stay alive and have a policy window, that detailed map I'm hearing, that's a logic model that can turn into evaluation of measures of quality adjusted life years saved by attaching segmented populations to the care that they need. You can measure access, and you can measure how that is saved by life years, but also cost to the coiffer. And so it's almost like I became a nurse to realize I should have gone to economics. Because I wish I knew how to do those fancy things to say, all these upstream early childhood supports, food programs, all the beautiful things, CHCs and the neighborhood health home will cost you this amount of dollars by saving in these other places. But everything we can talk about, and Natasha Musgrove was right, everything that we research and data, everything that we program plan, if you just think about it and put a health economics hat on, could model into cost-benefit analysis. And that's probably the missing link to the evidence, to implementation, to the policy window.
I don't have words to thank Rosie, what she told. Yes, absolutely I agree with you. Number one. Number two, the current system, that is current rapid, I borrow the language from Sarah, rapid attachment in event, it is a rapid binary administrative event. It is yes or no, 200. And as Hussam said, that out of thousands of people, a couple of 100, 600 people agreed and 400 people did not agree. That means, so we have to know more rather than volume-based matching to readiness-based. So readiness on behalf of the patient, residents, on behalf of the providers, on behalf of the system. That needs evaluation. Econometric evaluation. That is, what is the cost of investing in attachment and what is the cost of being non-attached. What is the difference between the two costings. So that thing we need. What is the social return on investment for attachment? Because government is spending millions. But at the end of 29, if we can say only 20% people could get attached out of the millions. So it is not social good return on investment. Waste of taxpayers' money. So this is the time we need to do correct econometric evaluation, not the metrics of numbers, but the quality of people's opinion. That is vulnerability metric that Cliff always says, vulnerability has got two perspectives, medical complexity and social complexity. So what are the social, why people don't agree, why they don't trust, and what is the meaning of readiness? That is, I am at trust. I am running non-insured clinic. One client came to the clinic, we cared them, we wrote some investigation, we paid for the investigation, and we referred to the specialist, we paid for the specialist, they needed language service, we paid for the language service, that is episodic care. The patient feels, yes, I am attached to Access Alliance. But if you ask the service provider, no, she is not attached. It was an episodic care. It is not attachment, means a temporary relationship between the service care provider and the consumer. So, how we can do that? If we can build trust. If it is a holistic team-based care. So, my final point is that we need good econometric evaluation. And I can tell you, with leadership of Jennifer and Sarah, Access Alliance is ready to do that. And we are doing very complex evaluations. We have good readiness metrics, not attachment metrics, attachment readiness indicators. We have already prepared those things. So things are ready, we are ready to go. So we need your collaboration, cooperation, and the funding. We are here.
So we have about 4 minutes left, so building on the idea of collaboration, given the policy window deadline that we can't fail to meet, but we must look beyond, and not just in terms of time, but also in scope to ensure access and equity occurs, and the fact that we think we know what we need, but the government might not. For you, Jen, and you're about to convene your annual conference, hundreds of people who are working on this issue, although the scope will be broader at your conference. What's your call to action for all of us to make sure that you have what you need, to make sure the government has what they need in order to make sure that the scope continues beyond?
So I'll speak with my researcher hat on. I think we need evidence to show what's working and what's not working and where there's gaps. I totally agree about the economic analysis. I think, we've done some amazing work looking at observed versus expected costs, and it's pretty simple. It doesn't even require it's not rocket science. It's pretty easy. So I feel like that's what we need, and we need to have it now, and we need to have it rapidly, and we need to feed that information back to the teams, but also serve it up to the government so they know what's working and what's not working. I think there's other things, but from my sort of research hat, I think that's what we need. And we can't wait 5 years to do it. We need to start we are doing it now. We need to do it now.
So given that everybody in this room might have some form of evidence, depending in that there's folks from the settlement sector, from the healthcare sector, but they're all worried about massaging that evidence into a way that looks good, is journalable. How can they get it to you regardless of its current format to say, listen, this happened, it worked, here's something that was an outcome?
So as part of our learning health system work, we try to take all sorts of evidence, whether it's gray literature, whether it's a case example. Izzy's here from the Alliance. She meets with people to talk about and learn what you're doing, and then we share it. We'll do lunch and learns. We try to aggressively share innovation, and we really try to highlight what's working. And then we also really support people when it's not working. So it's not like we hide that. We want to learn from each other and really learn what works. And policymakers attend those. So I think it's really important just to get that out there. So we've got our Epic News, we've got lunch and learns, we've got our learning collaboratives, we've got sharing circle, we've got communities of practice. Just share, and send me an email, and we'll make sure it gets. You always share stuff. We get it on our website. We share it out in our bulletin. We do lunch and learns. We just aggressively share.
So that's the call to action. It doesn't matter what format you have. If you have some evidence, some information, some ideas of what's working, just share it. They'll massage it. They'll work with you to figure out how to present it. But if they don't know, we can't move it forward.
Exactly.
Wonderful. Thank you, everybody. I want to thank the panelists. I want to thank you for all your time. This has been really insightful and interesting. We could go on for hours, and we will.